This lecture covers Chapter 31, Acute Leukemias. Acute leukemia refers to the rapid clonal proliferation in the bone marrow of your lymphoid or your myeloid progenitor cells, which are known as lymphoblasts and myeloblasts. In this lecture, we're going to discuss the classification schemes for some of the various acute leukemias, including acute lymphoblastic leukemia, acute myeloid leukemia, and acute leukemias of ambiguous lineage. We're also going to discuss some of the cytochemical stains that are used. Now, we have discussed a little bit about the classification schemes in previous lectures, which include the French, American, British, FAB classifications, and this was developed in the 1970s, and it's based off a morphological examination and the cytochemical stains, and it's going to differentiate the myeloblasts from the lymphoblasts. These classification schemes aren't referred to much anymore. However, you may still hear the terminology thrown out there a little bit. Most places are going to kind of use the WHO scheme for classification of the leukemias now. The WHO classification scheme is going to be based off of the chromosomal and genetic lesions. And this is related to disruptions of the oncogenes, tumor suppressor genes, and other regulatory elements that control the proliferation, maturation, apoptosis, and other cell functions. Now, WHO also classifies that at least a 20% blast within the bone marrow is required in order for a diagnosis to be made. And this is for a majority of the acute leukemias, in which it needs to be at least a 25% bone marrow blast ratio. And testing must be performed in order to detect the presence or the absence of some sort of genetic anomaly. Now I'd like to briefly discuss the incidences of acute leukemia. So with acute lymphoblastic leukemia, otherwise known as ALL, this is typically going to be a childhood cancer, and it makes up about 25% of the cancers, the childhood cancers, with up to 75% of those actually being a leukemia. The peak incidence for this particular neoplasm is going to be between the ages of 2 to 5 years of age. Within adults, it is rare, but the risk does increase with age. Most of these cases are going to be in patients that are over 50 years of age, and there is a poor outlook with 80 to 90% of the patients experiencing remission, but the cure rate is less than 40%. Acute myeloid leukemias, they are less common in childhood. Adults, this mostly affects adults, and it is the most common leukemia within the adults. And of course, the incidence does increase with age. The acute leukemias of ambiguous lineage, with these leukemias, there's really no clear evidence of differentiation along one particular cell line. And at present, the incidences of these particular neoplasms is unclear. So first we're going to discuss acute lymphoblastic leukemia. So this is going to be the leukemia of that lymphoid cell line. So within that lymphoid cell line, you're going to have the divisions that will fall between your B cell lineage and your T cell lineage. Now, clinical manifestations of both of them can be very similar. So you really got to be able to do the additional testing in order to kind of determine what classification these are going to fall in. But as far as the presentation for the B cell lineage, your clinical features are going to be fatigue due to anemia, fever, because there's neutropenia and infections that can take place. And you can also have the mucocutaneous bleeding, and this is going to be due to thrombocytopenia. You can also have the lymphatic system affected to cause some enlargement there, as well as enlargement within the spleen, the liver. And then you can also, these patients can present with bone pain. This is going to be due to that increased production of those leukomatic cells, those abnormal neoplasms that are starting to kind of At some point, they'll actually start to kind of infiltrate other areas of the body, like the meninges, the testes, the ovaries, even into the spinal fluid. And so you can also see these presentations that are going to be very similar with your T-cell lineage. Within that lineage, the patient can present with symptoms that are very similar, including the anemia, the thrombocytopenia, the enlarged organs, the bone pain, as well as some CSF involvement if there's any sort of infiltration that goes on as well. Now within your B-cell lineage, who does subclass them into 9 other additional categories, and then there's also a category that where something may not fit into one of the other 9 categories, so it's kind of otherwise not specified. And then within your T-cell lineage, there's not really an associated specific biological feature. So subcategorization for those early T-cell precursors can be very limited and very hard to kind of differentiate any kind of class within those. So you're not really going to have to know anything broken down any further as far as these different classes. Just be familiar with them. Your role as an MLT is just basically to find out that something's not normal, and then of course you'll just do your counts for your blast percentages and whatnot, and then you will send that referral to the pathologist, who will suggest something to the treating physician as far as what the suspicion is for the particular presentation, as well as any additional testing that they may want to recommend. Your book does list a chart that further breaks down those B-cell classifications by according to who, and you can see where it just kind of lists the abnormalities that take place as far as to diagnose that specific type. So with ALL, one of the main things that we're actually looking for, well, with any of these acute leukemias, is we're looking for that presentation of the 20% blast. So as an MLT, when you get a specimen that contains blast in it, and if the patient doesn't have a history, your main thing to do is follow your protocol of your site. So whatever they say, if you see this on a particular slide, then it needs to have a referral for pathology. So usually anytime there is a blast present, that's going to get a referral to the pathologist. So your job is going to be just to recognize that those blasts are there. Now you're not going to be expected to actually do the diagnosis. Again, that's going to be left up to pathology. But what you're looking for is the presentation of the lymphoblast. Now the lymphoblasts can vary in size, but they usually fall into 2 different types. So the most common type seen is a small lymphoblast. So this is going to be about 1 to 2.5 times larger than what a normal lymphocyte will look like. It's going to have a very scant blue cytoplasm with some indistinct nucleoli. The second type of lymphoblast are about 2 to 3 times the size of a normal lymphocyte, and they will actually have prominent nucleoli and then a nuclear membrane irregularities. So these cells can often be confused with AML. So that's why some of this testing is very important, so that you can kind of distinguish what lineage these cells actually come from. But we've got some examples here of some of the different cells or the different sizes of the lymphs that you can actually see. So you can see some that are a little bit smaller examples here in this top image. Those nucleoli are a little bit harder to see. You can kind of see some a little bit in that area. Here you can see an area where you've got a little nucleoli that's kind of present. With your larger ones, you can see those down here at the bottom where the nucleus itself is larger. You can see more of that cytoplasm around that cell. And then you can actually kind of see some of those nucleoli inside of that cell as well. This one's pretty clear. It's a little bit more clearer, where sometimes you can barely see them in those top ones, especially without being able to zoom in on this image a little bit better. Now the prognosis in ALL has improved a lot over the past several years as a result of improvements in the various treatment methods. However, prognosis can depend on the age at the time of diagnosis, the lymphoblast load or the tumor burden, the specific immunophenotype, and the genetic abnormality. Now, children rather than infants and teens usually do best as far as their prognosis. Now, chromosomal translocations are the strongest predictor of an adverse treatment outcome for children and adults. And as far as some of the laboratory findings or clinical presentations, if the peripheral blood lymphoblast count is greater than 20 to 30 and the patient presents with the enlarged spleen or being affected within the lymph nodes, then it's going to indicate that the outcome will be a little bit worse. Although morphology is the first tool that we actually use to distinguish ALL from AML, immunophenotyping and genetic analysis are the most reliable indicators of where exactly the cell lineage originates. Now, because both T and B cells are derived from the lymphoid progenitor cells, both of these cell lineages will actually express the CD34 markers as well as the TDT markers, which is your terminal deoxyribonucleotide and human leukocyte antigen with DR subregions. Now, your B cell antigens and your T cell antigens, they're going to have different expressions on those actual cells. And with your B cell lineage, you're actually going to have different expressions depending on the particular stage of development that B cell is in. Now, the 4 types of ALL can be further subdivided based off your immunological methods. And so you have the early BALL for the pro-B and the pre-B. You also have an immediate or common BALL. And then you have the pre-BALL, and then your TALL actually has another subdivision within it for the early T-cell precursor ALL. And so each of these, just depending on whether it's a B-cell lineage, T-cell lineage, it does have its own specific markers. And this is a nice table that comes from your textbook that actually lists some of the immunophenotypical characteristics of the ALL, and it just kind of gives those subtypes of it and what particular markers will be present. Now, there are cytogenetic abnormalities that are seen in the majority of B and T cell ALLs, and that's because there's some changes that affect normal B and T cell development, and so that's typically going to be the underlying pathogenesis of these neoplasms. Now, a majority of all the TALLs have been shown to have a gain-of-function mutation that's actually going to involve the Notch1 gene, in which it actually alters the Notch receptor signaling pathway that is responsible for normal T cell development. With your T cell lineage ALLs, the cytogenetic alterations show less specificity and less correlation with an actual prognosis and treatment outcome compared to your B cell or B cell lineage ALLs. With B lymphoblastic leukemia lymphomas, the one that is associated with the Philadelphia chromosome positive ALL has the worst prognosis, and it is more common in adults than it is in children. Now, I'm not expecting you to know what each of these are individually. Just know that based on which particular type it is, it does affect what the prognosis is for that patient. Now, with acute myeloid leukemia, our clinical presentation can be very similar. You're going to have the paleness, the fatigue, the bruising, the bleeding, the fever, but you're also going to see some other things that may be present, like DIC, malignant cell infiltration. Again, you're going to have those enlarged spleen. One thing that you do get with this is going to be a tumor lysis syndrome. Because you have a breakdown of dying cells, you can have some of those toxins and things that are going to be released. You're going to have That's where you're going to kind of see some of these laboratory findings, where you're going to see some results of some of that stuff that's happening, like the hyperuricemia due to the increased cellular turnover. So you're going to have that. You're also going to have the hyperphosphatemia. This is going to be due to that red cell lysis, so it's actually releasing that back into the circulation because those red cells are lysing, so the inside contents of that cell, red blood cells, actually leaching out, or any of those other cells that are being broken down. And of course you're going to have a lower calcium just because you've got some bone marrow destruction that's also going on. Now, as far as diagnosis, what you're going to see within your CBC, you could potentially see increased, decreased, or normal white blood cell count. It's just going to depend on the progression of the disease process. But you also are going to see things like anemia and thrombocytopenia. When you're reviewing your peripheral blood smear, you're going to see a lot of the myeloblast. Within the bone marrow, it could be hypercellular with greater than 20% blasts that are actually going to be present. And you could also do testing and find various genetic abnormalities. Now this chart here kind of breaks down how the WHO has classified these particular myeloid leukemias and related precursor neoplasms for the acute myeloid leukemia. So it's kind of broken down, well, basically based off the myeloid leukemias, and then some of those are classified as acute. But you have several of those that are kind of broken down here, and then we're going to kind of talk about these in a little bit, some of these in a little bit more detail. Again, I'm not expecting you to know each of these individually and everything that comes along with them. Just know what your myeloid line is going to present like. And here we have a list for AML, the recurrent genetic abnormalities, where WHO has further subclassified each of these individually. Now, I'm not expecting you to know each of them and what the various mutations are. It's going to be a little bit outside of your pay scale there. But as far as what you need to know is just some of the things that can kind of differentiate these a little bit as well will be the particular cell line in which, if there's a mutation, you may see some early precursor cells that are maybe, let's just say, from an eosinophil type line. So because this is a myeloid line, anything in that myeloid line, those granulocytes, you could see the early precursor cells of that particular cell lineage with these neoplasms. Acute myeloid leukemia with myelodysplastic related changes is going to affect primarily older adults, and it has a poor prognosis. So this incorporates leukemias with at least 20% blasts with a multilineage dysplasia and a history of myelodysplastic syndromes, or some sort of myeloproliferative neoplasm, or some sort of myelodysplastic syndrome associated with some sort of cytogenetic abnormality, except when there's a deletion of 9q. Now that involves something else. So for this particular disorder, you will see significant dysplastic morphology. So you'll have a pancytopenia with neutrophil hypogranulation or hypergranulation. You can see pseudo-Pelger-Hewitt cells and unusually segmented nucleoli. Now your erythrocyte precursors can have vacuoles. They can have some other abnormal looking features, including ring sideroblasts, and there may be dysplastic micro megakaryocytic and dysplastic megakaryocytes. So you're going to have some of those abnormal looking megakaryocytes with that platelet lineage. With therapy-related myeloid neoplasms, now this is just as the name suggests, due to treatment from something like chemo, radiation, what's going to happen is you can actually have other abnormalities that can take place, that the patient can actually develop the AML from as a secondary result to the actual treatment that the patient's getting. So those mutations are happening as a result of treatment. So you're trying to fix one problem and then you end up with another problem. I've actually seen this before in breast cancer patients where they get treated for breast cancer and then several years down the road they'll end up with acute myeloid leukemia, just simply because where that treatment has actually altered some of those cells and that genetic makeup. Because the leukemias in the not otherwise specified category don't actually easily fit into any of the subtypes that WHO has laid out, there are groups according to their morphology, so again, kind of based on those FAB classifications. And so again, this is going to kind of be based on the origin of the cell, the maturity of the cell, the cytochemical reactions, some of those other cytogenetic features. And so again, you do have to have at least a 20% presence of blast within the peripheral blood or bone marrow in order to make this diagnosis. Now, being able to diagnose the different classifications, it does require several different factors to be involved. Again, the main thing that you're going to have to take from this is looking for those blasts, and those blasts being in that myeloid line. There are some few things that can kind of differentiate one from another based off staining and CD markers or what's actually present in the peripheral blood. But again, this is not something that you're typically going to be expected to do as an MLT, is to actually make these calls and diagnoses. You only need to be familiar with that there are different classification systems based off of these laboratory findings. So one of the things I want to kind of point out, especially within your M2 classification, you can start seeing those IR rods being present in those blasts, whether it be in the bone marrow or in the peripheral blood smear. Once you start seeing IR rods inside of any sort of blast, then that is going to point you towards that AML. But as far as differentiating, it's going to depend on the staining, what particular blasts are present, and what CD markers are going to test positive. So those are listed here for each of these. I'm just kind of going to briefly run through them as far as like what you're looking for, something that kind of stands out. Again, you got those CD markers. You can kind of see some consistency with the same ones having the same positive CD markers. With your M2 or your AML with maturation, you may or may not have those IR rods present. And then your further classifications, once you hit that M3, you're going to have some real strong positive reactivity with your myeloperoxidase or your SSB stains. With this particular one, your book doesn't really mention much about it. You can still see this in a lot of your cell atlases. They'll still kind of describe this classification here. But you're looking for that bilobed kidney-shaped nucleus with those IR rods being present. Your M4 classification, again, is going to be based a lot off of those CD markers. Stains aren't really used a lot now, but you could see those, the esterase stain actually showing positive, and you can or may not have those IR rod present. Your M5 classification, now this is actually going to kind of touch more into your monocytic cell line, so you're looking for those monocytic type blasts to be present. And again, you may or may not have those IR rods present within those cells, and of course you got those CD markers listed. Then with your M6, you have that erythroid lineage that's being affected, so you're going to see those changes in all of your early erythroid cells. So if you start seeing those cells actually in the peripheral blood smear, then you can start seeing some weird stuff. You can actually see those cells dividing, so you might see multiple nucleus within those cells. So a lot of weird stuff that will go on with this particular, with the pure erythroid leukemia. And then your M7, you have your acute megakaryoblastic leukemia. So basically what you're looking for in here is those early platelet cells. So and what you're actually going to see is like some really large forms of those megakaryocytes. They're going to look really abnormal. And then of course you would use your special cytostains looking for things like von Willebrand's factors or platelet membrane antigens, and some of those CD markers to be present to indicate the megakaryocytes. So myeloid sarcoma actually is when you actually have some of those blasts that start proliferating from either one or more of those myeloid lineages, and it actually starts to disrupt the tissue architecture and causes some issues there. Myeloid proliferations related to Down syndrome. So it's been found that patients that actually have that trisomy 21 defect, chromosomal defect, that actually causes the Down syndrome, that they actually have a pattern of malignancy that it can happen within those patients. Blastic plasmacytoid dendritic cell neoplasm. So this is a rare clinically aggressive tumor that is derived from those precursor plasmacytoid cells that can actually cause this neoplasm as well. The acute leukemias of ambiguous lineage, which are also known as acute undifferentiated leukemias, these will be the leukemias in which there's no clear evidence of a differentiation along one particular cell lineage. And so this kind of morphs over into the mixed phenotype acute leukemias. And this is where you have these cases of the acute leukemias of ambiguous lineage that demonstrate a multiplicity of antigens in which you can't really determine which lineage is affected. So it's just multiple different lineages that could be affected with this particular type. The WHO classifications will include the acute undifferentiated leukemia, which is basically, it's going to be kind of used with the same context as AL. So there's no differentiation. It's a primitive acute leukemia, stem cell leukemia. With your mixed phenotype, of course, it can be multiple lineages that are involved that can be further differentiated based on some other genetic type testing. And then, of course, you have acute leukemias of ambiguous lineage that are not otherwise classified. So they basically don't know exactly where to put these in yet. And again, it's just because there's no clear definition of actually what cell lineage is affected. So lastly, we're just going to kind of briefly discuss the various cytochemical stains that can be used to help with identifying these particular leukemias. Now, the newer techniques do include flow cytometry, cytogenetic analysis, and molecular testing. However, some of the older techniques that you may still find them actually in practice this is going to include myeloperoxidase, the enzymes found in the primary granules of granulocytes. They exhibit the myeloperoxidase activity. So these particular stains are going to kind of target that particular component of those granules. So lymphocytes do not exhibit any sort of myeloperoxidase activity. So this particular stain is going to be used to differentiate blasts to determine are they from a myeloid lineage or are they from a lymphoid lineage. So if you see positive reactivity, then you know it's more of that it's a myeloid lineage. The Sedan Black B stains actually stain cellular lipids, and you're going to use these stains to also help differentiate AML from ALL because it's actually going to stain, again, it's got to do with those granules being present. So you're going to see your myeloid stem cell lineage that's going to retain that stain. And your esterase stains are going to differentiate your myeloblasts and your granulocytic lineage from your monocytes. So there are a couple of different stains that can be used. You have the non-specific stains as well as the specific stains that's going to be looking for that esterase. Your non-specific is going to look for that esterase activity in the monocytes, but it's not going to be present in the granulocytes. And then your specific stains are going to be positive in your granulocytes, but negative or very weak reactivity in your monocyte line. And there is a very useful chart in your textbook that actually kind of lists and differentiate those stains and which ones will be positive in which particular condition.